to introduce yourself in the chat. The chat icon can be found at the bottom of your screen. I'm also going to throw a couple links into the chat there for a quick survey. The state of Colorado does ask us to collect a little bit of demographic information for those who are attending today. And the purpose of this is just to help us figure out a little bit more about who's in attendance and who we still need to reach to get a little bit more information and set our priorities for the community. And then, as Rob said, we're planning on having some conversation at the end, but if you do have questions that come up, please feel free to throw them in the chat. We might not be able to stop the presentation to ask them in the or answer them in the moment, but we will prioritize those when we get started in the group discussion at the end. But thank y'all. And then Stacy, if you'd like to move forward for the next one, I'm going to post those links in the chat, and those links are going to be available in both English and in Spanish.
And it looks like some of our attendees are indicating that the chat is closed currently.
Ah.
All right. Our colleague Leslie Strawbridge is on our Zoom call. We're going to ask Leslie if you can help open that chat up. That would be great. So Leslie will problem solve that. I'm just going to keep going. All right. So we want to first start the meeting by sharing with you what our current community health needs assessment and HTP work has been. So for Valley View, our current community health needs assessment is from 2021. I want to pause and acknowledge many people on this call today, and the community at large were incredible partners in the process to really help inform Valley View's selection of our community health needs and how we come up with an implementation plan to address those needs. So these two needs that you see on your screen, improve coverage and total cost of care and address community behavioral and mental health needs, have been the focus of our work since 2021, and again, stemming from our community health needs assessment. So we want to just take a few minutes. Rob and I are going to kind of tag team this together to talk about those community benefit activities and the resulting financial investments that we've also made. So kind of the slides are going to be oriented in the following manner. So on the left, you're going to see within the need of improved coverage and total cost of care. That is what you as our community told us is a need and an opportunity for Valley View to address. You're going to see on the left-hand side what impact we've been working to create. So first and foremost, we've been working to improve coverage specifically for our vulnerable populations. On the right-hand side, you're going to see some of the key actions and strategies associated with that, which we're not going to read through, but really the intention of this work has been to make sure that for the vulnerable members of our community, for those who have additional challenges, that Valley View is really leaning in and trying to take down some of those barriers to their care. So you can see starting at the top, really even looking internally to make sure that we as an organization are operating efficiently so that we can ensure coverage for all of our patients. Another key cornerstone has been a financial aid program that we've provided to our community members for families of up to 500% of the federal poverty level. This has been a real investment, not only a financial investment, but we have an amazing team of Valley View financial counselors who stand ready to work with any of our patients through any of the programming and opportunity and financial assistance that we can provide them to ensure that they are getting the coverage and the care that they need. We've also been working with payers around contracting opportunities, and also have been really grateful for the partnership. I'm not sure if Chris is on this meeting yet, but with the Valley Health Alliance and other initiatives to really look at individual employer-based insurance options in our community. So just wanted to start with that. Rob, anything on that you want to chime in and touch on as well?
I think that's a good overview. Sometimes, putting some numbers with these topics can speak a lot. And so, when we look back at the last year that we have the finalized IRS submissions, we looked in 2022 that we delivered over $24 million in charity care to our community. And so we'll pause on this again on a later slide, but I do think that sometimes, attaching numbers to the work that we're doing further elicits, some of the things that we're doing for our community as we care for our friends and neighbors and family.
Great. Thank you, Rob. All right, I'm just going to keep moving on. So, another impact that we've been working to create is enhancing primary care, which in turn can help manage the total cost of care. Some of my provider colleagues share about primary care kind of being that quarterback in a person's health and well-being. And so we really lean in and focus on primary care. That can make a really huge difference in terms of improving our community members' coverage. So on the right-hand side, again, you can see how we've been focused on that. So in addition to, having the region's largest network of primary care here at Valley View, we've also made some other investments. So just to kind of highlight some, we are very proud partners with our local public school district to provide their certified athletic trainer program. So making sure that our student athletes have access to real-time care should they need it, but also making sure that they can get into primary care or additional services as needed. I'm not sure who is on from Mountain Family, but they are great partners. And in turn, we provide direct financial support for them, specifically Mountain Family Health Centers, which is located across the street from Valley View Hospital here in Glenwood Springs, with a direct financial contribution of $400,000 a year to make sure that our federally qualified health center can provide the great services that it does to our community. While we are proud of the Valley View network of primary care, we also do work with non-Valley View primary care practices in our valley, again, with that sense of, if we can elevate together the availability and the access to primary care, the health of our community improves. So we work with Glenwood Medical Associates and Mid-Valley Practice to help in the recruitment of their primary care providers. And then also we're a part of the Quality Health Network, supporting collaboration across our whole medical community in the care of patients. And we cover that cost for our entire medical staff to be part of QHN, and that's about $700,000 a year. So some specific examples, and to Rob's point, just wanting to make sure that the financial investment we're making or the financial costs that we're making related to this is also clear, and we're being transparent with you as our community in that regard as well. Rob, anything else?
I'd like to just highlight, some of the strong work that I think Valley View is offering to address this community need in the form of, what I would summarize as primary care wraparound services, things that aren't necessarily always directly tied to a dollar amount, but things that we're doing on a day in, day out basis to help demonstrate the true caring for our community. So some of those examples are care coordination that we have in our each of our primary care practices, and integrated behavioral health that we'll get to as well in a little bit here. But our inpatient crisis team that's unique for Valley View. Certainly, we also work with the entities in the community like the Hope Center, but internally, if someone is admitted through the emergency room, we do staff a crisis team internally. We have diabetes programming through our cardiopulmonary rehab center. As Stacy mentioned, our athletic trainers that we place free of charge at our local schools for all events. And then, just collaborating as partners with the community entities. Just this morning, I had a really meaningful phone call with some providers at Mountain Family Health Center around supporting safety net care and ways that we improve and enhance transitions of care and work collaboratively. I think we have good relationships that take energy, effort, and it's what we feel most meaningful, that we really connect those patients to the best resources.
Okay, Rob, you're on a roll. I'm going to ask you to just keep stepping through some of the great work and other examples that we have in this space.
Yeah, perfect. So, within primary care, some of these will associate with our HTP measures that I'll kind of hold off on describing now as we get to a list a little bit later in the slide deck. But transitions of care can be complicated, and we want to make sure that we're providing information in a timely manner. So one of the things that we measure is transmission of electronic summaries of care back to primary care and beyond. That's become a standardized platform nationally, but takes a fair amount of infrastructure internally in order to facilitate that. We support patients in multiple languages. We use both in-person translators who are certified. We also have a fairly significant number of our providers at Valley View who are, if not native Spanish speakers, have gotten additional training and certification for that, which patients typically express appreciation around. But we also use, if we don't have those services immediately available, a really strong electronic platform for translation services. And that's really for any and all languages that patients may have for their preferred language, which we wish to respect for all care. And so that platform, which happens to be called Propio, is a point of care tablet-based system that can either do audio only or audio and visual presence for the translator to interpret visits. We recognize that living in a rural area, we have geographic challenges and, mobility barriers within transportation. And so we seek to optimize our telehealth opportunities. And that works really in two ways for patients. That may be a patient at home or even after hours who hops on a video call with a provider to get a timely care optimally with their primary care provider, who maybe has that longitudinal perspective to their conditions. But it may also be someone who needs the help of a specialist or a subspecialist, and that can be facilitated through one of our practices or as an inpatient. For example, if someone presented to our emergency department with acute stroke symptoms, although we have neurology as a specialty here at Valley View, we know subspecialist as a stroke-focused neurologist is critically important in a time-sensitive manner. And so we wheel in a special computer that gets somebody from a tertiary care facility like University Hospital or elsewhere to help evaluate those patients in real time with specific conditions. And there are a number of other specialties we use in similar approaches, whether that's infectious disease, rheumatology, et cetera. So we feel that that really enhances care in our community. And then lastly, on this slide, you'll see, just diverse populations through understanding things like social determinants that we're going to also pause on here later. But trauma-informed care in caring for special populations, for example, trauma-informed care was the topic for our continuing education that happened just minutes ago that was delivered to our providers. And that continuing education series that we offer every Wednesday is also offered to community providers, even those who are not employed at Valley View. Once again, really trying to stay on the cutting edge, not just of clinical care needs, but also providing care for diverse populations.
Great. Thanks, Rob. So moving on, our implementation plan related to improving the coverage and total cost of care. We're also just kind of continuing on the remarks, Rob, you were starting to make, is really to make sure that our understanding of our patient well-being drives more effective strategies for wellness, as well as cost management. And so you'll see on your right-hand side, this focuses us on assessing those health-related social needs, and then also making sure that our patients can be referred for services and support. Rob, as a provider, what does that look like for you in the care of your patients?
Great question. And I know the slide here says specifically for Medicaid patients, but it's really not just limited to Medicaid. That element was highlighted in regard to the HTP program, Hospital Transformation Program, which is a state initiative we'll be touching on here in a few minutes. But it's really for all patients. Every patient admitted to Valley View is administered a standardized health determinant screener that works to identify social determinants of care, things like transportation needs, food insecurities, housing insecurities, any domestic concerns, health literacy, all these different elements that really factor into a patient's care, and that we realistically understand through some medical literature that it constitutes a bigger portion of health outcomes than maybe whether somebody takes their blood pressure medicine. Still important, but we think that about 80% of those social determinants actually influence health outcomes a lot more so than maybe just our standardized medical practice that we're all used to. So along the same lines, referring patients with positive social needs to another entity then as the next step. How do we prioritize resources within the community? So we work on some really novel platforms that I think are leading, really cutting edge in Western Colorado. Through the Health Information Exchange, we have a program called CRN, Community Resource Network. And through that, we make referrals to community entities. That may be for Medicaid patients, something called the RAE, the Regional Accountability Entity, who have resources at hand. But that may also be, different, very specific community resources, Caring Bridge, or the food bank, or transportation assistance through the Traveler or other local entities. And so it's pretty efficient that we can recognize and then provide referrals for patients who are interested to those resources.
Great. Thanks, Rob. All right. So moving on, this is another area we're hopefully working to affect change. And as we've already talked about, kind of with primary care being this very essential foundation to not only health, but to our work to improve coverage and total cost of care. Our focus now shifts to accessible quality specialty care. And on the right, you can see kind of some layers of work that we're doing. So looking first at Valley View and the specialty care that we provide that is unique to our region. So that's 24/7, 365 cardiovascular care, spine care, comprehensive cancer care. So really making sure that those are anchored and accessible to our community, but also making sure that we're continuing to evolve. So our most recent example is the addition of palliative care as a specialty service, both in the outpatient and inpatient setting here at Valley View, is really a significant addition to making sure that, again, community members can have access to specialty care close to home. Also, we make a pivot to making sure that we can work with our incredible regional hospitals. So Aspen Valley Hospital, Grand River, the hospitals in Craig, Meeker, Rangeley. We are so grateful for the opportunity to have regional partnerships with them so that our specialists can either travel on a regular basis, have regular scheduled clinics so that they too and their community members and their patients can also have access. So looking beyond Valley View's particular primary care, primary service area, and looking beyond that into the larger Western Slope region.
Tracy, I think it's worth pausing here just to kind of frame this in the specialty care that Valley View offers the community, in that it's unique in a rural area to offer the number and depth of services that we see here. Mm-hmm. And although if we do that well, it's streamlined and it looks easy. But the truth is, things that look easy sometimes aren't. And so an example here is kind of the cost associated with providing things like 24/7 coverage for medical subspecialties that can be expensive to offer. And so I think, again, kind of highlighting some of the numbers, it's worth pausing around. So one number that you won't see on our public-facing IRS submissions is how much we spend on locums services every year. And locums are doctors that fill in for vacation and part-time coverage if you don't have that continuity. And we have at least 5 to 6 different areas in the hospital where we have to have that 24/7 availability, who we don't necessarily have enough individual providers hired or employed to provide that 24/7 coverage. So that's in the tune of $6 million a year for those locums providers that Valley View has to pay for. And you wouldn't see that in a rural area, in a metro area, because the volumes are higher, the staffing is higher, and it's just a little bit different equation on how you provide those services. So I think it's worth pausing on that as a community benefit that really is afforded here locally, and how we prioritize recognizing the need to keep care close to home.
And I appreciate that too, Rob, because certainly I feel like emergencies don't happen necessarily during business hours or when they're convenient, but certainly they are extremely scary. So thank you for stepping us through that.
Sure.
So this is looking at how we can better manage our costs through the appropriate use of care. We're super excited and pleased with the success of our after-hours urgent care. So this creates another means for patients to seek timely care. This is here at Valley View Hospital. It's adjacent to the emergency room. Whether you have a cough or a cold or something that you really feel cannot wait for a primary care appointment, but also perhaps doesn't necessitate a trip to the emergency department, walk in, there's no appointment needed. And one of the things that I've heard from our community members is that is fantastic for our physical location of our urgent care is that because it's adjacent to the emergency department, should there be an elevated need for care, that team is right there. So again, just trying to make sure and recognizing the emergency department is the highest cost of care location in our healthcare system, but also knowing that people need timely care as well. So that's one significant example of making sure that people can access the appropriate use of care. Also,
yeah, maybe I'll take these second two, Stacy, just
please.
because
Yeah.
These are also HTP measures, but there's one called the hospital index measure. It really looks at procedural episodes of care and whether or not there was any potentially avoidable costs associated with those episodes. So it gets pretty complicated pretty quickly, but I think suffice it to say, we get into the details to make sure that we are optimizing the healthcare dollar and utilization of services to be efficient and safe as we provide that care day in and day out. On the next one, the last one here we have is really around length of stay, a topic we look at and once again kind of dive into data around on a regular basis to make sure that we are keeping care efficient if someone's hospitalized and that we know people are better off when they're at home. We want to get them stabilized, healthy, and back at home. And so one of the metrics is just how long they're in the hospital, and the cost associated with that, once again, is utilization measure.
Thanks, Rob. All right, we're going to pivot to our next need, which is community behavioral and mental health needs. I think this is a significant topic of conversation across our community. And so we're just going to take a few minutes again to go through the impacts that we've wanted to create in addressing this community health needs and creating community benefit. So first, we want to promote access to quality psychiatric care. We're super grateful to have Dr. Pete Wiley here as a member of the Valley View team. Also, what we've been doing is making investments to hire 2 psychiatric nurse practitioners. And I say this as an investment because this is a line of business, so to speak, a service for our patients that Valley View provides that operates at a loss. So again, just getting back to the intentionality of, making sure that our community has access to the psychiatric care is something that we are driven to by our mission, but from a business perspective, we are certainly making an investment in it.
Yeah, I think it's worth just, noting you don't see necessarily those services offered at every hospital, especially rural facilities, just because of the cost equation with reimbursement within the American healthcare structure.
Thanks. All right, Rob, you want to talk about how we've been looking at integration between behavioral and physical health care?
Would love to, yes. One of the things I enjoy talking to my patients about is, that mind-body connection that sometimes we underestimate. And along those lines, we have pursued behavioral health integration at all of our primary care locations and clinics. We really value that. And that's regardless of, sometimes those services aren't reimbursable, but we feel it really enhances the quality of care and keeping our patients safe. And so those are available at each of our primary care locations. It also decreases stigma to have the opportunity to do a warm handoff and recognize, oh, this doesn't have to be a big deal. I can take care of all of my mind and body needs, and it doesn't have to feel stigmatized. So those closed loop referrals for community-based behavioral health, as I talked about through the Community Resource Network. And then, important to, just as some of the regulatory programs highlight, screen for some of these conditions. A big one is postpartum anxiety and depression. And so we screen multiple times for every pregnant patient and after delivery, looking proactively for depression and anxiety, with resources at the ready, both in an integrated fashion here at our family birthplace and women's health, as well as ability to refer to those important community resources that were mentioned earlier. And then finally, discharge planning and referrals for mental health and substance use disorders. Super important, especially as we've seen things like the opioid epidemic that we have not just a good pulse on, but are well adept at navigating not just those clinical needs, but also the resources for the wraparound services that patients need if they're afflicted with some of these conditions. So we do that both in the inpatient and ambulatory settings.
Right. So we have 3 more places that we want to share, and then I think we're going to try to move through that quickly, Rob, and then turn things back
Good.
over to Megan.
Yep, Alto is a pretty straightforward one.
Decreased, decreased
I would-
opioid use. Can you just speak
Yep,
to
that's in the
Alto?
emergency department, and
Mhm.
specifically when we treat patients for pain in the emergency department, we want to optimize use of a non-opioid medication first, and that's what this measure really looks at. So you can keep on clicking through slides here. And our zero suicide initiative is pretty straightforward in the title there, but this is an all hands on deck program. We seek to have all staff, even non-clinical staff, at Valley View, familiar with warning signs, familiar with mechanisms for screening, and immediately referral resources and wraparound services for patients who could be at higher risk for suicide. We know that that's a condition that afflicts Western Colorado at a higher rate than it does the state average, and Colorado at a higher rate than the national average. We take this very seriously, and we really do have a true all hands on deck approach to zero suicide.
Okay.
Substance withdrawal, again, along those same lines with substance use disorder, but I think what really we want to highlight here is our brand new facility that Stacy has very much invested in, so I'll let her take that one.
Yeah, and I think this is such a project that is truly reflective of the power of partnerships. So want to thank and acknowledge Mind Springs, all of our local municipalities, Garfield County, really for coming together, Grand River Health, to be part of a community collaborative to, again, look at that substance recovery continuum and make sure that here in Glenwood Springs, we have withdrawal management services. So that facility opened in June 2024. We are collaborating partners, but also financial investors. So for us to help see that new facility come online, we contributed and made an investment of $100,000 into that building, and are again at the table and continuing to work with a great group of partners. All right, Rob, this is the slide that gives hopefully additional transparency into, again, through our most recent IRS 990 tax filing, where those investments really kind of translated from a dollar perspective and those funding amounts. So certainly as a Valley View employee and a community member, I am very proud and grateful for the investments that have been made from a financial perspective that have fueled the work that we just previously spoke of.
Perfect. Thank you, Stacy.
And then just to summarize HTP, Rob.
Yeah, HTP state program really facilitated for patients who have Medicaid health insurance, but really we know it can be a proxy for all the patients that we care for. And we have 10 measures or initiatives that we work on under this program, much of which we were already pursuing prior to the launch of the HTP program, but certainly the program has strengthened us and strengthened the care that we offer for our community. So I want to just quickly clip through these, but I'm happy to take questions maybe in that later section of our meeting here. So 30-day readmission rates, making sure that patients who have stroke are discharged with a statin or cholesterol lowering medication that's standard of care, that we're screening for those social needs and notifying the RAE if they're positive, screening for postpartum depression, as I mentioned earlier, that we have discharge planning and notification for patients with substance use and mental health disorders. The Altos I talked about earlier is reducing use of opioids in our emergency department. The hospital index measure is that one related to episodes of care for really procedural things. If you're getting a knee replacement, if you're having a surgery for a colon concern, or on and on, we want to make sure that we're in line with the costs associated with those episodes. So a lot of data there. Increasing the transmission of a summary of care. That's that electronic kind of pass through for medical records that go back to the primary care provider and beyond. And then finally, these last two, the length of stay that I touched on earlier, and the urgent care that is adjacent to our ED also falls within this program. It's certainly not why we launched our urgent care. We feel like that's good care for our community if someone can't get in with their primary care provider. And I do stress that heavily. Primary care knows the longitudinal needs of the patient more than anyone else could. But if your primary care provider isn't available at that moment, or you're here from out of town, it's nice to have that urgent care option next to the ED.
Awesome.
All right. Thank you, Rob. Thank you to everyone for that whirlwind step through, but I think it cues up nicely, Megan, where you're taking us next in this meeting and conversation. So over to you.
Awesome. Thank you. And if you go ahead and advance to the next slide here. So all of these updates were informed through a process called a community health needs assessment that we conducted 3 years ago as part of the hospital transformation program. It's also an IRS mandated stipulation as far as maintaining the tax status of the hospital. And then there is another state initiative that's come out. It's a community health benefit that's also leaning into this process. So just a little bit of background as to what's been done in the past and what we've been doing for the last couple months is this process needs to occur every 3 years. And so as we've been mentioning, these are updates on the 2021 CHNA. But the last 3 months, we've actually been conducting your 2024 CHNA. And so the way that process works is we do this through a stepwise approach. Step one is taking a look at the quantitative analysis. So taking a look at the landscape, the publicly available health data. We take a look at some claims data as well to get a big picture idea of what's going on in the community health-wise. And then while we're taking a look at that, we started conducting a survey, which is that step 2 here. And then right where we're at now is about that step 3, step 4 area. So we're working on developing those priorities so that the hospital can start initiating a plan just like they did in 2021, with the overall goal being reaching a state of health equity.
Sorry.
No, you're good. Perfect. So the process takes a look at health services specifically, but it also takes a look at a wide range of social determinants of health. So we've just highlighted a couple of things here, but when we go through this process, we ask community members who are participating to keep in mind their own experiences and what they're seeing in the community as a whole. Health is affected by so many things outside of just direct health services. And so we want to make sure that we're taking a look at the big picture when we set priorities for the facility. If you want to go ahead and advance here, thank you. So the process that we've been going through, we started this in June with the community, and that was, again, taking a look at an environmental scan of publicly available health data. We took a look specifically at some health metrics, but we also took a long look at some of the social determinants of health data that was available. We did conduct that health needs survey, and then we held 2 meetings to discuss the results of both of those processes. In those meetings, we invited people from various different other entities throughout the community that provide health and social services to get an idea of what their populations are experiencing, and then wanted to bring that conversation here to the larger community to get some perspective from everybody. At each of those meetings, we did ask those groups to discuss what their vision of the community looks like as a result of the data that we had presented. So we asked them to provide us with insight as to data that might be missing, that might be of interest for us to continue looking at, and then just any sort of gaps in where the data and the actual health needs meet. Go ahead and skip it. Thank you.
For everyone in the meeting, I am doing the PowerPoint, so that's why I'm smiling while Megan's talking. So yeah.
Just a quick overview of who we collected data on. We did specifically look at the residents of Eagle, Garfield, and Pitkin counties just because this is the primary service area for the facility. But whenever possible, we try to take a look at the state data as well as national data so that we have some comparisons and some benchmarks so that we can see how the community is doing as a whole, but how it also compares to the state and national levels. And then just as a point of reference, some of my personal favorite places to collect some of this data I've linked here on the slide. So if anybody's interested in popping in and seeing some of that data from time to time, those are my favorite references. We also will be including in the full report access to the slide decks from those first two presentations so that you'll have access to all the data that was presented in the previous meetings. And then go ahead. Thank you. I won't go over all of the information on this slide because again, it'll be accessible in the final report, but this slide goes over some of the highlights where the data was just a little bit outside of the benchmarks for the state and national levels. So just some really interesting tidbits. The life expectancy in the community averages about 88 years, but is as high as I think 93. Yeah, 93 years of age in Pitkin County. So your patients are living longer than the patients in the state of Colorado. And in some of the areas of this community, Pitkin County, for example, has a pretty high percentage of residents that are in this aging category. So your patients are living longer and you have more of them than the rest of the state of Colorado. We also took a look at a lot of data around the cost of living in this community as well as housing. The home to value or home to income ratio for your community is some of the highest, not just in the state, but in the nation, with Pitkin County seeing a ratio of over 7 and a comfortable rate actually sits pretty close to 2.5. So it's pretty significant. And this was something we spent a lot of time talking about in the community meetings. We also saw a lot of conversation and a lot of data around anxiety and depression scores. So you do have some of the highest rates of anxiety and depression in the community. And as Rob mentioned, there's a significant need for suicide resources on the Western Slope, but in the state of Colorado in general. And if you could skip forward. And again, a lot of this data is going to be available in the report, so I won't read everything on here for you, but we did conduct a survey in the community to get an idea of what everybody else is seeing. And the top 4 health concerns were mental health problems, aging problems, cancer, and substance abuse. We also asked what specialty services people were obtaining. And those top 4 were dental, physical therapy, ortho, and dermatology. And then the top 4 health services that were being utilized were primary care, surgery, specialty care, and the emergency room. We did also ask about the delay in care. This was something we spent quite a bit of time talking about in one of our community meetings. And on this survey, we had about almost 42% indicated that they had not received services within the last 3 years. And we asked them why they delayed or refused services. And the top 3 reasons were cost, that it was too long to wait for an appointment, or they couldn't get an appointment. And if you could skip forward. Yep.
Okay.
And then just a little background on who completed that survey. We had about 974 responses. We have had a couple more come in since we closed the survey and collected this data. So we're still looking at that information as it comes in. But at the time of creating this slide deck, 974 responses were in, 13 of which were completed in Spanish. A very large portion of the population that completed this survey was in the 65 to 84 age range, most of which having at least some college education. And then we did have an overwhelmingly larger number of females complete the survey, most of which were white. And then you can see the zip codes for those that had completed the survey, and most of those are local. And 90% of those are permanent residents of those zip codes. And then go for it, Stacy.
Okay, here we go.
And then just some quick highlights in the conversations that we had. I've mentioned this as it tied to some of the data, but a lot of interest in the access to physical and mental health services. We also talked quite a bit about substance abuse issues. Again, the high cost of living, particularly around housing. We talked a little bit about why care is being delayed, and a lot about health insurance coverage, particularly around Medicaid and Medicare. And then if you could advance, Stacy. So after having these conversations, we did ask what the biggest needs in the community are. And these are in no particular order, but these were what came through those conversations. Access to care, particularly mental health services and substance abuse. We were asked to address the issue of delayed care, and then some around some of the cost of care things, so preventative care and health insurance. We did have some questions about the reliability of some of this data, just because it is a rural community. Some of those things don't quite get captured as well as they do in urban areas. So we had some questions about whether or not there could be some benefit to addressing the data needs in real time. And then again, cost of living and how it impacts specifically the social determinants of health and health outcomes. And then if you could advance, Stacy. So out of those conversations, we heard 3 kind of buckets of overall priorities. And those buckets were total cost of care, access and availability of care, and the social determinants of health. And of those buckets, the things that we've been hearing that the community would like us to start focusing on are under total cost of care, decreasing hospitalization and ED visits, taking a look at the patient education on prevention and primary care to help reduce the cost of admittance to places like the ED, improving coverage for vulnerable populations, which is actually a continuation of the 2021 plan. Enhancing primary care, which again is a continuation of the 2021 plan, and incorporation of the social determinants of health screenings. Again, another continuation of the 2021 plan. And then we were asked to evaluate and expand current financial assistance programming. So a lot of these things are things that the hospital has already been working on as a result of the last community health needs assessment. But we're still hearing that these are issues that the community would like us to continue addressing. As far as access and availability, we decided as a group that mental health and behavioral health fell kind of into this bucket with physical health. So trying to continue bridging that gap between the two of those things and addressing overall access and availability of care. And again, a lot of these initiatives are continuations of the 2021 plan, such as fostering bilingual access, sophisticating that connection between behavioral and primary care, developing procedures around those positive screenings that Rob had mentioned and those discharge planning, continuing to decrease the use of opioids, providing patient education on what services are currently available and how to access those, as well as evaluating the outmigration of those commonly used services to see if those are things we might be able to start bringing in-house. And then the last big bucket is the social determinants of health. And while a lot of these things are things that are a little bit outside the scope of how the hospital practices, we decided as a group that this is something that the hospital could start helping to inform from the health perspective of some of these social determinants of health. And so we were asked if we could start focusing a little bit more on developing relationships with partners in the community that are already doing this work. And so some potential partners that came out of that conversation are listed here on the right. We are going to ask you as a group if there are others that you would like us to consider setting up meetings and regular conversations with, so that we can help inform some of these outcomes and maybe find areas where we can partner, whether that is sharing financial resources, applying for grants together, or developing referral relationships. And that brings us to the discussion portion of this. So I'd like to open it up here. I believe everyone should have access to unmute themselves. If you don't, I think we'll just have you guys raise your hand and we can work on unmuting you. But just wanted to open up here and hear your thoughts on how things have been going as far as the updates on the previous CHNA, And then also would love to hear your feedback on how things are going for this current CHNA and where we should be continuing to focus our efforts for the next 3 years.
Looks like Andrea has raised her hand. I'm not sure if she can unmute herself or if we need help with that.
I have asked her to
Oh,
unmute. She
There
cannot.
she is. Hi, Andrea.
Hey, sorry, I didn't raise my hand, but I'm happy to just mention that I really appreciate all of the information. It feels very thorough and being involved from the community perspective. Just wanted to say thank you for all of your hard work.
Thanks, Andrea. I appreciate you and your leadership of the chamber and our business community. Thank you.
Thank you.
Awesome. And while people are gathering their thoughts or figuring out how to unmute or raise your hand, I also wanted to just remind you and point you to the links for our demographics survey. If you haven't been able to take a quick minute to pull that up, if you can do that either before we wrap up here or shortly after, that would really help us out a lot. Sarah, looks like you're not able to unmute. If you want to comment, you can also comment in the chat. Looks like those are coming through and we're happy to read those out loud too.
And I'm not hearing too many other folks unmute. Leslie, are our folks needing kind of a manual override to get off of mute?
Sorry. Yes, Sarah Sims, if you can hear me, I should have you unmuted.
I can hear you. Can you hear me?
Yes.
Yes.
Awesome. Great. So thank you for this process and thanks for walking through the last plan and the steps going forward for the next plan. We're excited to be a partner with Valley View Hospital in this effort. Many of you know that we provide supports to a unique population who is vulnerable, especially to medical issues. You know, many people who we support are polymedicated. They have different communication skills. They're not always able to understand or to communicate what is happening. And so it takes additional steps and additional efforts. And while Valley View has done well with that in the past, I look forward to even increasing our partnership with Valley View to enhance that a little bit more. So thank you for that opportunity.
Well, thank you, Sarah, because I definitely think you guys do incredible work. And again, I think that perspective of expertise and what your clients and those you serve in the community really need, particularly as you say, when they come into the healthcare system, you know, absolutely, if there's opportunity for more partnerships so we can be more effective and thoughtful. Thank you for that.
Absolutely. And, you know, Stacy, it's reciprocal too, because, you know, we have a lot of individuals who seek out additional medical visits that may or may not be medically necessary.
Okay.
So we appreciate the understanding that Valley View has given us in regards to them and addressing that issue. We also have the overlay of CDPH&E's regs and requirements that enable or require us to seek additional medical intervention that, you know, that someone not in our services would not necessarily take.
Understood. Okay.
And Sarah, just for the benefit of the group, will you highlight your organization again, please?
Yeah.
Sure. And my name could have come across as something other than my own. I don't know. I've used this computer.
No,
for a
you're
couple
still Sarah.
different things.
You're
Okay. Thank you, Stacey. So I'm with Mountain Valley Developmental Services. We are a service provider for people who have intellectual and developmental disabilities and delays. We serve people throughout their lifespan, from infancy and throughout, you know, the end of life. And we support people in Garfield, Pitkin, Lake, and Eagle counties.
Thank you, Sarah.
What are we doing?
I'm-
Any other chats?
Gary, can you hear me?
Yes, I can. And
All
you,
right,
and
there you go.
first of all, what's Rob's last name?
Yeah, Rob Nelson. I'm a physician assistant at our internal medicine office, and I work as the quality director here at Valley View.
Millicent, did you say it?
Nelson, Nelson.
Okay. I may make an one appointment to talk to you. Is the 990 federal tax report available to the public?
It is.
Yes, it is.
Okay, I would like to acquire that.
Okay.
Was a survey done of the professionals, care providers, in the valley as well? Or is this all from customers, patients, people who come for service?
The survey was administered to both. Yeah, we definitely did have some professionals complete the survey, and a lot of patients and community members as well.
Okay.
Good question, Gary. Thank you for that.
I've been a customer for 27 years.
Mm.
I've watched the growth. It's spectacular. I don't think I could get better healthcare anywhere. I can jump in my car and be in the doctor's office in 20 minutes.
Mm.
And you can't do that in any major city. So I'm a big fan, but I've noticed an awful lot of changes in the company, the two, CEO changes. And I would like an opportunity to chat with Rob or somebody like that I know an ex-board member who I plan to have lunch with. And so I'm just trying to be prepared for that. And I just like to confirm some of my observations with you, Rob, in such a case that I could talk with an ex-board director.
Wonderful. Yeah, I relish those opportunities, Gary. In fact, it was just a day or two ago, I had a great phone call with a community member, and I really value that, whether that's positive feedback, but maybe even more importantly, when it's constructive and when we have opportunities to even enhance our services or collaborations or what have you. So I take it real seriously, and I relish that opportunity. Megan, at the end on our last slide, if you want to flip to that, I think have our contact information posted right there.
I just put
with
it
the
up, Rob.
emails.
Yep.
And so, yeah, by all means, feel free to shoot me an email, Gary, and I really do apply my due diligence in getting back to emails. If I don't get right back to you, please send it again. But I try to get to all of them.
Okay, good. Well, it's this whole thing is something you would not find in a rural hospital like this, I wouldn't think. So hats off to whoever decided you need to do this work. My concerns are much more at the provider level, and the mode of administration and the mode of staffing and some of those things that could certainly use improvement and may not be getting focused on. I don't know.
Great. Yeah. Again, would love to chat with you, Gary. Thank you.
Okay, I will. Thank you.
Mary Kenyon, can you hear me?
I can hear you. Can you hear me?
Yes,
We
we
can.
can.
Excellent.
Hi, Mary.
Hi, how are you?
Great to have you on this call. Thank you.
Thank you, Stacy. And I'm sorry I was late. One of our volunteers didn't come today, so I had to jump in and do a meal delivery route. So my name is Mary Kenyon. I run the Meals on Wheels program called Valley Meals and More for Eastern Garfield County. And we work very closely with the hospital discharge folks. Don't know their official titles, but they reach out to us when someone's being discharged and needs meals for either a short term or a long term, or if they're noticing that someone can use the help of nutrition on a regular basis, they do reach out to us. And I put in the chat that I would love to be Valley Meals to be added to your list of partners, because we're all about preventing hospitalizations and premature institutionalization because of the inability to get proper nutrition. I actually was negotiating with an older adult yesterday because he had blood running down both of his legs and he wouldn't let me call the paramedics.
Mm.
So we have very stoic older adults, and anything we can do to work closely with the hospital and staff to help them get care without ending up in an ambulance to get to the emergency room, we're happy to do that. And so I too will reach out to you guys and make sure that you know what we're doing and what we can do. And I would like to talk further about, on a corporate level, we're looking into medically tailored meals and prescriptive produce, working very closely with Kroger Health on the East Coast and their registered dietitians, so that we can offer your patients more options on those discharge meals, because sometimes they're so medically tailored that what we're currently offering doesn't fit. But we're moving in that direction, and I actually just received a fairly large grant to pursue that over the next 2 years. So you're my partner, so I'll be knocking on your door. So thank you for doing this. I'm sorry I missed the first half, but I took copious notes once I jumped on.
Phenomenal, Mary. Thank you for what
Yeah.
you're doing for our community members. If you're not already, I'd love to make sure that we partner with you through
Absolutely.
Community Resource Network to facilitate streamlined referrals. And if you have any questions about that, perhaps you're already on it. If not, we can certainly chat offline.
Sounds great. Thank you.
Along those notes, Rob, there's a question in the chat from Heath Harmon about how can partners continue to work with Valley View on some of these priorities and strategies. I know there's ample opportunities as far as like the process for HTP goes, but do you guys have formal avenues in which you would like to continue working with some of these partners established, or do you need some assistance in putting those together?
Great question. I really think it's a little bit topic dependent, but I'll highlight some of the different venues and options. So first, I want to just, we have an open door policy for taking input and as I said, chatting with folks to kind of customize what direction or who we're putting in on point for those interactions. But there are already some public venues that we have a strong presence at, such as West Mountain Regional Health Alliance, that works with a lot of community resource entities, as well as various providers in the community, not to mention entities like Valley Health Alliance, that kind of plays an overlapping role between health insurance landscape and employers, as well as the health delivery landscape.
Uh-oh, did we lose Rob?
Possibly. I was wondering if it was just my computer.
Me too.
I can't hear him either.
Okay, I think we did lose Rob.
Oh, no. I will just chime in and say, Heath, appreciate the question. And I think specific to this process, for those of you, we've got our email addresses up. Would love, just send us an email if there are thoughts, opportunities, strategies where we could specifically collaborate on hopefully moving forward with these identified health priorities. We would love to hear from you, because again, that implementation plan will allow us to really lay out how we can hopefully best partner, whether it's, Eagle County or Mountain Valley Developmental Services, and make sure that we can all work in a complementary fashion. I do think as part of this process, we've had great representation from our local public health departments, for which we're very grateful. And in as much as their community health projects and priorities also align and complement, we want to be part of that as well. So just drop us an email, open door. Okay, back to you, Megan. I don't think you're frozen, are you?
I am not frozen. I
Okay.
don't think. I don't see anything else coming through the chat.
Well,
It looks like all the hands.
I had Samantha, are you still there? I saw your hand up earlier. Samantha?
I'm not hearing anybody.
I can't see her unmuting, so
Okay. Thank you, Leslie.
you're welcome.
That looks like all the hands and all of the questions in the chat. Stacy, if you wanted to wrap up, I know you had a final thought on timelines.
Sure. So just to share with you all, our next steps, both Rob and I will be bringing back this work, these recommendations to the leadership at Valley View for formal adoption. So really formally saying, these are the health priorities that we're going to work on as Valley View for the next 3 years. Subsequently from that, we will be developing an implementation plan, which hopefully, further develops strategies and actions, but also those partnerships and reaching out to you to be part of broader collaborations. So we ask if you have any thoughts, insights that could further inform the selection of these priorities, the development of the implementation plan. Please reach out to any of us. You have our emails, and we'd love to hear from you within the next 30 days to really create a window, but also hopefully allow us to move forward. And then I think, moving forward, we are committed, to continuing meetings and conversations like this. So creating, kind of this formal event. But I think just the collaboration and the engagement today and throughout this whole process has just been so inspiring. So I want to thank everybody for taking the time. I know there's incredible work occurring across this community every single day. Thank you for allowing Valley View to be part of this community and supporting us in addressing these community health needs, and your commitment and help to, moving all of this forward. This is big, important work, and we're grateful for each of you and the organizations and communities that you represent. So those are our next steps. Plus gratitude. I kind of did it all. All right. So again, I want to thank Megan, our interpreter Diana. We've had great IT colleagues here in the background helping us navigate Zoom, which you think we would have figured out through COVID. So thanks to the many people with us for this meeting. Thanks to each of you, and you will be hearing from us. And please don't hesitate to reach out as well. Thank you guys for your time today. Appreciate it. Bye.
Bye.
Thank you.